ఎక్కడ? అక్కడ లేదు, అక్కడ లేదు. రాలేదు, రాలేదు, రాలేదు.
Good morning, everybody. So, with respect to the classes pertaining to nutrition, we have covered several nutritional deficiency diseases and problems and issues such as fluorosis, and then Lathyrism, and then about food safety, legislations with respect to food safety, and also about pasteurization and things like that. Now today, probably this will be the last class or second last class with in this topic of nutrition. So, while covering anemia, we have covered and learned few things about iron and folic acid supplementation activities that are going on in the country. And similarly, with respect to xerophthalmia, we spoke at length about Vitamin A mass prophylaxis program and all those things. Other than this, what are the programs which are being taken up by Government of India to ensure that undernutrition is under control? Because time and again I have been specifying that behind many of the nutritional deficiencies, there is just one reason, that is food. And micronutrient deficiencies and macronutrient deficiencies, that is deficiencies of calories and protein, that is macronutrient deficiency. And micronutrient deficiencies are all these things which we have been talking about: anemia, vitamin A deficiency, vitamin D deficiency, vitamin B complex deficiency, whatever they are. They are all only a corollary. They are all corollary to one issue, that is food gap. So, what government is doing about this aspect? What are the government programs which have been launched and which are in operation all throughout the country right now? Introduction. India is the second most populous country in the world next to China. Among its population, majority of the people belonging to rural community, and they are from low socioeconomic status, illiteracy and lack of basic human needs. From the nutritional point of view, majority are undernourished and only a small group are well fed. The high income groups are suffering from diseases of overnourishment. So the specific causes for nutritional deficiency disorders are low socioeconomic status, illiteracy, lack of awareness regarding nutrients and their requirement, and then overpopulation, decreased food production, lack of healthcare facilities, large families, cultural influences, infections, overnourishment among the group of high socioeconomic status, superstitious beliefs, misconceptions, and limited availability, inadequacy of food products, dietary practices, etc. So, whenever you come across a question in theory question or short note type of question or long question, these are the causes which you have to invariably narrate, enlist. So this is a very, very important slide, and every point, if you write point by point, may it be vitamin A deficiency, may it be anemia, may it be protein energy malnutrition. Say, don't say Lathyrism and fluorosis. Even there also some of them hold good. So These are the specific causes for nutritional deficiency disorders. The major nutritional problems in India are, I have already enlisted: protein energy malnutrition, nutritional anemia, iodine deficiency disorder, vitamin A deficiency, low birth weight, endemic fluorosis, Lathyrism, and marked distortion, cardiovascular diseases and cancer. Of course, I didn't speak anything to you about cardiovascular diseases, obesity and all those things, which are the problems of overnutrition. The protein energy malnutrition. Malnutrition is a significant loss of lean tissue or inadequate diet for a prolonged period in the setting of severe stress. It is a significant component of many diseases. Malnutrition is more a condition. It is not, you can't call it as a disease. It has become almost a natural condition. Right now, nearly among the under fives, at one point of time, the prevalence of undernutrition was around 47%, and now it has reduced. Definitely, it has reduced to 31%. But that also is not. That is, it is a condition where one third, like illiteracy, like poverty, that also is a condition. As far as we doctors are concerned, we should treat that as a condition, not as a disease. And we have to keep in mind that this is one of the confounding factors whenever you want to treat a particular disease. So, 1 in every 3 malnourished children in the world lives in India, and every third child in India itself are undernourished. Malnutrition limits development and the capacity to learn. It also causes loss. About 50% of all childhood deaths are attributed to malnutrition. In India, around 46% of all children below the age of 3 are too small for their age. 47% are underweight, and at least 16% are wasted. Wasting is one of the manifestations of acute undernutrition. Many of these children are severely malnourished. The prevalence of malnutrition varies across states, with Madhya Pradesh recording the highest rate, 55%, and Kerala among the lowest, that is 27%. So, anemia. So, every age group is vulnerable to iron deficiency anemia. I have spoken at length about iron cycle, the life cycle of iron deficiency. In children, anemia can cause a 5 to 10 point deficiency in IQ and hamper growth and language development. In adolescence, it leads to a fall in academic performance with a dip in memory and concentration levels. It can also lead to physical exhaustion and susceptibility to infection. 65% of the infants and toddlers, 1 to 6 years, 65% of the infants, toddlers 60%, 60% of 1 to 6 years of age, and 88% of adolescent girls, and 85% pregnant women suffer from anemia, and 9.9%, roughly 10% are having severe anemia. The prevalence of anemia was marginally higher in the lactating woman as compared to pregnancy. The commonest is iron deficiency anemia. So the current situation in India, 1 in every 2 Indian women suffers from some form of anemia. 4 out of every 5 children in the age 6 to 35 months suffer from anemia. 20% of the maternal deaths are due to anemia, and anemia indirectly contributes to another 40% of maternal deaths. And maternal mortality is staggeringly high at, this is a little old figure, now it is around 236 per every 1 lakh live births. This 454, it was there in somewhere in 1990. Now this figure is exaggerated. And then the results not commensurate with 30 years of efforts by the Indian government. So, vitamin A deficiency. Vitamin A is necessary for good eyesight. In children, vitamin A deficiency causes a loss of eyesight. That is, all these things: bited spots, xerophthalmia, corneal xerosis, and then keratomalacia, corneal ulceration, and all those things. So vitamin A deficiency causes loss of eyesight. If this deficiency is very severe, it may lead to permanent blindness. In our country, every year 30,000 children lose eyesight due to vitamin A deficiency. Vitamin A deficiency symptoms are seen more severely in children of age group 1 to 5 years. It is estimated that there are 12.5 million economically blind persons in India. Of these, over 80% of blindness is due to cataract. Say iodine deficiency disorders. Now, iodine deficiency disorders have been recognized as a public health problem in India since mid-20s. Iodine deficiency disorder is not only a problem in sub-Himalayan region but also in riverine and coastal areas. Now, even East Godavari district also we have seen, we found cases of iodine deficiency appearing. According to Union Ministry of Health, it is estimated that 71 million populations are suffering from endemic goiter and about 8.8 million people have mental motor handicap due to iodine deficiency. Statistics furnished by the Ministry of Health and Family Welfare in its report tabulated during 2011 revealed that 1.3 crore people in UP alone are suffering from iodine deficiency disorder. The figures of Madhya Pradesh and Bihar stood at 0.82 crores and 0.62 crores respectively. The spread of IDD is far and wide, with poverty being a key driver. And low birth weight. More than 20 million infants are born each year weighing less than 2,500 grams, accounting for 17% of all births in the developing world, a rate more than double the level of industrialized countries. And infants with low birth weight are at higher risk of dying during their early months and years. Those who survive are liable to have an impaired immune system and may suffer a higher incidence of such chronic illnesses as diabetes and heart disease in later life. Fluorosis. Fluorosis is a disease caused due to excessive ingestion of fluoride. Fluorides are the compounds of fluorine. Fluorine is the 13th most abundant element available in the Earth's crust. As the surface water passes through the fluoride-rich rocks, it carries fluoride with it. Hence, most of the fluoride is found in groundwater than surface water. Permissible limit of fluoride, as per WHO, is only 1 milligram per liter, as a safe limit for human consumption. Whereas several districts of Rajasthan India are consuming water with fluoride concentrations of up to 24 to 44 milligrams per liter. Even in our Nalgonda district and Nellore district, Prakasam district, in all these areas, it may not be this high, but it is around 16 to 21 milligrams per liter. In India, the problem has reached alarming proportions affecting at least 17 states of India. Out of those, 5 are hyperendemic, where 50 to 100% districts are affected. Example, Andhra Pradesh, Tamil Nadu, Uttar Pradesh, Gujarat and Rajasthan. Even now, Karnataka also has joined in this list. So, Lathyrysm. So, Lathyrysm disease occurs by consuming large quantities of Lathyrus sativus, Kesari Dal. Lathyrism in humans is referred as Neurolathyrism. The disease presents as a crippling disease of nervous system, characterized by gradually developing spastic paralysis of lower limbs. Kesari Dal contains a toxin called beta-oxalyl amino Alanine, BOAA, and Lathyrus or Kesari Dal is a good source of protein. It is relatively cheaper. Hence, it is consumed by people belonging to low socioeconomic status. Now, obesity. It is the most prevalent form of overnutrition. Abnormal growth of adipose tissue due to enlargement of fat cells, that is hypertrophic obesity, and increase in number of fat cells, hyperplastic, or combination of both. India is now at the grip of obesity epidemic and the trend needs to be immediately arrested. By taxing junk food, restricting food ads, and making food labeling clearer, etc. are the measures which are required. Currently, almost 1 in 5 men and over 1 in 6 women are overweight in some urban areas. Now, this is the problem of emerging problem in the urban areas. Now, cardiovascular diseases. Cardiovascular diseases classified as one of the food habit related illnesses. Change in food habits and lifestyle has increased the risk of CVD in Indian population, mostly in middle class and upper middle class groups. The World Health Organization reports published in medical journals like Lancet and the Indian Heart Journal suggest that by 2010 there will be close to 100 million this is 2020. There will be close to 100 million cardiac patients in India. WHO has also estimated that by 2030, India will have 60% of world's cardiac patients, and in another 5 years, it is likely to become the world capital for heart ailments. On an average, about 2 million patients in India currently undergo cardiovascular surgical procedures every year. While 4% of the Indian population suffered from heart disease in 1980, it rose to 10% in 2003. Deaths due to heart ailments also increased from 14 deaths per 1 lakh population in 1985 to 260 deaths per 1 lakh population in 2003. So cancer. Recent times have seen an increase in the incidence of cancer. This is mainly attributed to urbanization. It is not that directly related to nutrition. In India, the life expectancy at birth has steadily risen from 45 years in 1971 to 62 years in 1991, indicating a shift in the demographic profile. It is estimated that life expectancy of the Indian population will increase to 70 years by 25. This has caused a paradigm shift in the disease pattern from communicable diseases to non-communicable diseases. It is causing, it has not yet caused communicable disease, especially we are in the midst of a COVID-19 pandemic. There is no point in telling that, only there is a paradigm shift with respect to disease pattern. Cancer prevalence in India is estimated to be around 2.5 million with over 8 lakh new cases and 5 lakh 50,000 deaths occurring each year due to this disease. More than 70% of the cases report for diagnosis and treatment services in the advanced stages of the disease, which has led to poor survival and high mortality rate. So major nutritional programs which government of India is taking up to tackle this issue are as follows. So major nutritional programs are, the government of India has launched many nationwide health programs to improve and restore the health status of the vulnerable population, such as infants, preschoolers, school children, antenatal and postnatal mothers, etc. Currently, major nutritional supplementation programs in India are Integrated Child Development Services Scheme. Most of you would have gone to Anganwadi Center located in Kanpur, and then midday meal programs, that is midday meal programs especially amongst the school children, and then special nutrition programs and wheat-based nutrition programs, and then applied nutrition programs and Balwadi nutrition programs, and the National Nutritional Anemia Prophylaxis Program, and the National Program for Prevention of Blindness due to Vitamin A Deficiency, and National Goiter Control Program, and Antyodaya Anna Yojana, and other programs. Several other states have, for instance, Tamil Nadu Integrated Nutrition Program, like that. Integrated Child Development Services Schemes. Integrated Child Development Services Scheme was launched on 2nd October 1975 in pursuance of the National Policy for Children in 33 experimental blocks. Success of this scheme led to its expansion to 2,996 projects by the end of March 1994. Now the goal is to universalization of ICDS throughout the country. Almost now it is universalized. The primary responsibility for the implementation of the programs is with the Department of Women and Child Development Ministry of Human Resources, and the nodal departments at the state, which may be social welfare, rural development, tribal welfare, health and family welfare, or women and child development. Beneficiaries: children below 6 years, pregnant and lactating women, women in the age group of 15 to 44 years, adolescent girls in selected blocks. Since 1990, the plan aims to universalize the ICDS, that is coverage to the whole country. Objectives: improve the nutrition and health status of children in the age group of 0 to 6 years. Here I may add one more thing. Say we cannot separate the problem of infection and the problem of malnutrition. So even these Anganwadi centers are tagged with vaccination activities. 6 vaccine preventable diseases. The vaccines are being administered to the children through these Anganwadi centers on allotted day. Probably you are already aware of this. So lay the foundation for proper psychological, physical and social development of the child. Effective coordination and implementation of policy among the various departments, and enhance the capability of the mother to look after the normal health and nutrition needs through proper nutrition and health education. The package of services provided by ICDS are supplementary nutrition, that is, they provide either nutritional supplements or cooked food and egg and rice with dal or some vegetable, and then iron and folic acid, and then immunization, health checkups, and referral services, treatment of minor illnesses, nutrition and health education to women, and then preschool education of children in the age group of 3 to 6 years, and convergence of other supportive services like water supply, sanitation, etc. So, actually, in every village, Anganwadi center has become a place from where the basic objectives of primary health care and the basic inputs which are required for effective implementation of primary health care are given at each village level. And for every 1000 population, there will be one Anganwadi worker. So, scheme for adolescent girls, Kishori Shakti Yojana. Common services are: all adolescent girls in the age group of 11 to 18 years receive the following common services: watch over menarche, immunization, general health checkup once in every 6 months, training for minor ailments, deworming, prophylactic measures against anemia, goiter, vitamin deficiency, etc. Now coming to deworming, say most of you, while talking about anemia, I have told you, one of the aggravating factors with respect to iron deficiency anemia is hookworm infestation, ankylostoma duodenale. So what we are doing is to give albendazole 400 milligrams in a single dose at an interval of once in 6 months, what we call as mass deworming. So this is being carried out through schools as well as through Anganwadi centers. So prophylactic measures against anemia, goiter, vitamin deficiency, etc., and referral to PHC district hospital in case of acute need. So midday meal programs. The midday meal scheme is the popular name for school meal programs in India, which started in 1960s. It involves provision of lunch free of cost to the school children on all working days, protecting children from classroom hunger, increasing school enrollment and attendance, and strengthening child nutrition and literacy, improved socialization among children belonging to all castes, addressing malnutrition and social environment through provision of employment to women. Beneficiaries: children attending the primary school, children belonging to backward classes, scheduled castes and scheduled tribes families are given priority. The scheme covers students class 1 to 4 in the government primary schools aided by government, and the primary schools run by local bodies. Food grains are supplied free of cost, 100 grams per child per school day, where cooked/processed hot meal is being served with a minimum content of 300 calories and 8 to 12 grams of protein each day of school for a minimum of 200 days, and 3 kg per student per month for 9 to 11 months in a year, where food grains are distributed in raw form. In drought affected areas, midday meal is distributed in summer vacations also. So, special nutrition programs. The program was launched in the country in 1970 to 71 to improve the nutritional status of specific target groups. It provides supplementary feeding of about 300 calories and 10 grams of protein to preschool. These values they will be asking you in the Viva as and when you appear for examination, preventive medicine examination. So, these values you have to remember. It provides supplementary feeding of about 300 calories and 10 grams of protein to preschool children. How about school children? So, 300 calories and 8 to 12 grams of protein. For them also the same thing. Objectives. Improve the nutritional status of species. See, the aim of this is not to, these are all not substitute to food. These are supplements to food, whatever midday meal program or supplement, special nutrition program. Improves the nutritional status of specific target groups, provides supplementary nutrition, supply of vitamin A solution, iron and folic acid tablets. Beneficiaries, children under 6 years, pregnant and lactating mothers. The program is operated in the urban slums, tribal areas, backward and rural areas. Children under 6 years, 300 kilocalories per. Now, the special nutrition program is integrated with the ICDS. Now, applied nutrition programs. Now, these are not being implemented right now. Previously, they implemented for some time. The applied nutrition program was introduced as a pilot scheme in Orissa in 1963, which later on extended to Tamil Nadu and Uttar Pradesh, promoting production of protective foods such as vegetables and fruits, make people conscious of their nutritional needs, and provide supplementary nutrition to children aged between 3 to 6 years and to pregnant and lactating women. Beneficiaries, children between 2 to 6 years and pregnant and lactating mothers. During 1973, it was extended to all the states of the country. The nutritional education was the main focus, and efforts were directed to teach rural communities through demonstration how to produce food for their consumption through their own efforts. The idea is to provide better seeds and encourage kitchen gardens, poultry farming, beehive keeping, etc. But this program did not produce any impact. The community kitchens and school gardens could not function properly due to lack of suitable land, irrigation facilities, and low financial investment. So, this Balwadi nutrition program, this is nothing but Balwadi nutrition program was introduced in 1970 to provide nutritional support to the children. It is nothing but ICDs. Yes, I don't want to elaborate on this. And National Nutritional Anemia Prophylaxis Program. The program was launched in 1970 to prevent nutritional anemia in mothers and children. This program is being taken up by the Maternal and Child Health Division of Ministry of Health and Family Welfare. Now it is part of RCH program. Beneficiaries, children in the age group of 1 to 5 years, pregnant and nursing mothers, and female acceptors of IUDs and terminal methods of family planning. Under this, now adolescents also have been brought into this program's purview. Under this program, the expected and nursing mothers as well as acceptors of family planning are given one tablet of iron and folic acid containing 60 milligrams elemental iron, which was raised to 100 milligrams elemental iron. However, folic acid content remained the same, 0.5 milligrams of folic acid. And children in the age group 1 to 5 years are given one tablet of iron containing 20 milligrams of elemental iron. For children 6 to 60 months, ferrous sulfate and folic acid should be provided in liquid formulation containing 20 milligrams elemental iron and 100 micrograms of folic acid. Dispersible tablets have an advantage over liquid formulations in programmatic conditions. These have been used effectively in other parts of the world and in large-scale Indian studies. The logistics of introducing dispersible formulation of iron and folic acid should be expedited under the program. The current program recommendations for pregnant and lactating women should be continued. So, school children 6 to 10 years and 11 to 18 years old should also be included in the National Nutritional Anemia Prophylaxis Program. These are the certain recommendations. So, National Program for Prevention of Blindness due to Vitamin A Deficiency. So, it is estimated that there are 12.5 million economically blind persons in India. Of these, over 80% of blindness is due to cataract. The National Blindness Control Programme started in 1976 as a 100% centrally sponsored program. The National Prophylaxis Program for Prevention of Blindness due to Vitamin A Deficiency is implemented through primary health centers and its subcenters. They are responsible for administering vitamin A concentrates to children less than 5 years. Every infant between 6 to 11 months and children in between 1 to 5 years are to be administered vitamin A every 6 months. Priority should be given to children in between 6 months and 3 years since they have the highest prevalence of clinical sign of vitamin A deficiency. The targets set up under the 9th plan are 17.5 million cataract operations. Almost all now we have doubled it. Actually now it is nearly 35 million. Beneficiaries children below 5 years of age. Objectives: prevention of blindness due to vitamin A deficiency, supplementation of vitamin A to all the children below 5 years of age, providing comprehensive eye care services at primary, secondary and tertiary healthcare level, and achieving substantial reduction in the prevalence of eye diseases in general and blindness in particular. Wheat-based nutrition programs. This has been the feature of some states actually. Wheat-based nutrition program is a centrally sponsored program was introduced in 1986 but now transferred to the state sector. This program follows the norms of SNP or of the Special Nutrition Program or of the nutrition components of ICDS. Central assistance for the program consists of supply of free wheat and supportive costs for other ingredients, cooking, transporting, etc. The scheme is implemented by the Ministry of Women and Child Development. National Iodine Deficiency Disorder Control Program. Iodine is an essential micronutrient with an average daily at 100 to 150 micrograms for normal human growth and development. Deficiency of iodine can cause physical and mental retardation, cretinism, abortions, stillbirth, deaf mutism, squint and various types of goiter. It is estimated that more than 71 million persons are suffering from goiter and other iodine deficiency disorders. The government is implementing the National Iodine Deficiency Disorders Control Program, formerly known as the National Goiter Control Program, since 1962, a 100% centrally assisted program with a focus on the provision of iodated salt. And the program was initially called as Goiter Control Program and was renamed by Government of India in 1992 as NIDDCP. Surveillance of goiter cases, supply of iodized salt, monitoring through analysis of salt and urine samples, and assessment of impact of control measures over a period of time. Now this is Antyodaya Anna Yojana. The Antyodaya Anna Yojana was launched in December 2000 for 1 crore poorest of the poor families. AAY contemplates identification of poorest of the poor families from amongst the below poverty line families covered under targeted public distribution system within the states and providing them food grains at a highly subsidized rate of Rs 2 per kg for wheat and Rs 3 per kg for rice. The scale of issue that was initially 25 kg per family per month has been increased to 35 kg per family per month with effect from 1st April 2002. Antyodaya, and this is not for the entire population, you please note it. Those people who are below poverty line also are not given this. Only some selected persons on a selected, poorest of the poor. That is what the program says. The following criteria will be adopted for identification of additional Antyodaya families. Landless agricultural laborers, marginal farmers, rural artisans, households headed by a widow or terminally ill persons, disabled persons, persons aged 60 years or more, widows or terminally ill persons or disabled persons, all primary tribal households, and then, as announced in the union budget, AAY has further been expanded to cover another 50 lakh BPL households. Other programs include emergency feeding program. This was introduced in May 2011 in selected states. Emergency food feeding program is a food-based intervention targeted for old, infirm and destitute persons belonging to BPL households to provide them food security in their distress conditions. Cooked food containing rice 200 grams, dal 40 grams and vegetables 30 grams is provided in the diet of each of these people. Village Grain Bank Scheme. Village Grain Bank Scheme implemented by the Ministry of Tribal Affairs. This is for tribal areas to provide safeguard against starvation during the period of a natural calamity or during lean season. National Food for Work Program. The National Food for Work Program to provide supplementary wage employment and food security. That is, so Pulse production has been stagnant for 5 decades. Pulse Mission, India's food security mission, aimed at increasing pulse production, aimed to improve pulse production by 2 million tons. So this National Rural Health Mission, that is basically a medical, it has brought about radical transformations in medical care, in primary health care delivery. So that also is helpful. That's all. Indirect programs. Thank you.
Good morning, students. So this is the question paper for your unit test. Please read all the questions properly and you have to finish this in 1 hour.